got this chance and opportunity to discuss uh, what is essentially a very important topic. And I do hope my slides are visible.
Yes, sir.
Uh, this is each time we speak on Dapagliflozin, we have to speak of something new. So the term is new this time. The data is more or less what you all already know. I have been asked many times as to you show one new thing in your presentation. So I think the new thing is metabolic diuretic promise of the Dapagliflozin. There is some. We are going to talk about Dapagliflozin by three different viewpoints. And the viewpoint of nephrologist, which Dr. Ratan Shah would be speaking about, and Dr. Shastri, and I and an endocrinologist who will speak about the metabolic aspects. Most of you would have seen this picture if you've been to Brussels. This is a picture of a boy who had, according to the folklore, urinated on the wires that were to blow a bomb which would have destroyed the castle of a nobleman. I don't know if that story is true or it's a figment of imagination, but this picture is very popular. And those of you who go to Brussels always will get to see it near the center square. SGLT2 inhibitors have the propensity to increase the glucose excretion in the urine, and nobody ever believed that by that mechanism, they would be able to diffuse the twin bombs, the cardiovascular, and also the renal components of diabetes. And now they have extended the benefits beyond the diabetic population. And this is truly revealing. We were controlling this disease by all measures which would reduce glycosuria. And when these drugs were introduced, people were wondering, how could a drug that causes glycosuria actually benefit diabetics? But all of you know that this is indeed the case. We know that there are many issues with diabetes. It is also with chronic complications, including neuropathy and retinopathy, which are not the topic of discussion today. But there are interactions between the diabetes, cardiovascular system, and renal disease. You have hypertension, coronary heart disease, heart failure with or without vascular disease, and you obviously have issues of NASH, obesity, atherosclerotic diabetic dyslipidemia, and diabetes. In the renal component, which Dr. Jha will be talking about, you have issues of glomerulosclerosis, and you have a crosstalk between the kidneys and the heart, one leading to worsening of the other. In recent times, ever since their introduction, after the initial controversies of tumors, blood tumors with the SGLT2 inhibitor DAPA was doused, issues of stroke and postural hypertension with canagliflozin were gone. They have come a long way and are approved for use by almost all the guidelines. The ADA, the ASD, ACE, and the cardiologists associations also have pitched in to give their prominence in the disorders that they are so good at managing. The Endocrine Society, RSSGI also have endorsed these guidelines. We know that we have 4 different categories for the sake of simplicity in managing diabetes when we choose anti-hyperglycemic agents. On the extreme left, we have got patients who've got ASCVD or high risk for ASCVD with individuals more than 55, with 50% stenosis of the carotids or the peripheral vascular disease, people who have got proteinuria or CKD. These individuals and those who have heart failure or CKD are suggested to get either GLP-1 analogs or SGLT2 inhibitors. For heart failure and CKD, the predominance is for heart failure, for SGLT2 inhibitors. Second in order is the GLP-1 analogs. When it comes to avoiding hypoglycemia, we have many agents, the DPOR inhibitors, the SGLT2s, type glitazones in our country, even for that matter, drugs like GLP-1 analogs and alpha-glucosidase inhibitors. Then you have drugs that cause weight loss, in which you have GLP-1 analogs and you have got SGLT2 inhibitors. And even they are cost constrained, people are supposed to use sulfonylureas, and or glutazones. Progressively, for various reasons, the cost factor has been erased for the use of deep throat inhibitors by some of the companies in our country. The patent violations or the patent expiry of certain deep throat inhibitors and certain SGLT inhibitors have made the drugs within the reach of many people. So if you look at SGLT inhibitors, they are not just in the limited category of patients who got ASCVD, heart failure, CKD, but also as agents that do not cause hypoglycemia, cause weight loss, and also the cost is now being reachable within the range of most people. The ACE guidelines also are somewhat similar, and you would notice that SGLT inhibitors are recommended in people who have got atherosclerotic cardiovascular disease, but also as tier 2 drugs in individuals who require dual agents or triple agent therapy. In the kidney disease patients, it is said that they should be given lifestyle modification. First line therapy is metformin, and now the guidelines are saying that you could even start between 30 to 45 at half the dosage. You do not have to worry about metformin, but metformin alone may not be able to control. And because of the benefits that people have seen with SGLT inhibitors, they say that it might be appropriate to add these drugs to background RAS blockade with ACE inhibitors or ARBs. Up to GFR 30, we have got now a recommendation to add drugs like Dapagliflozin, but also up to 2025 might be possible when you have approval for DAPA after the DAPA CKD, which Dr. Ratan will suggest, will discuss. However, one might point out here that the SGLT2 drugs are very good at such GFRs for renal protection, but they're not such great agents for glycemic control. It says two things. A, the renal protection is independent of glycemic control, and B, for glycemic control, you may require other agents like deep throat inhibitor, insulin, sulfonylureas, or what else you have. The European Society, which I think Shastri will allude to, have placed SGLT inhibitors much before metformin in drug-naive people. They say that you might use SGLT inhibitors, GLP-1 analogs in patients who are drug-naive and who have got ASCVD, which means that people are at risk because of age, because of dyslipidemia, smoking, and CKD. In individuals who are already on these drugs, they suggest that you must put these people on SGLT inhibitors. Inherent in this is the finding that these drugs have benefits not just because of anti-hyperglycemic properties, so they are given independent of HbA1c. That means if somebody is under control with drugs that do not include this, you are suggested to make a change to these drugs even when the person is at target. And this is also relevant for CKD and heart failure when you know that there is data now for patients having benefit even when they do not have diabetes. And what is more, in the DAPA heart failure study, which Shastri will allude to, there was a decrease in the new onset diabetes. We know that heart failure leads to diabetes, diabetes leads to heart failure. So what nicer thing would be to prevent diabetes in sectors of heart failure patients. Now, Indian phenotype, we know that we are insulin resistant. We have got abdominal obesity, we have got low levels of adiponectin, and we have got atherosclerotic, atherogenic diabetic dyslipidemia, which is high triglycerides, low HDL, a structurally abnormal LDL, and maybe quantitatively normal LDL. And we have got increased susceptibility to the vascular disease. The glycemic efficacy of dapagliflozin, which we often tend to ignore, thinking that it's only for those subset of patients, is quick in action, is sustained, and the word durability is actually a little bit of a scary word, but it seems to have its action for a fairly long period of time, has been studied for 2 years and more. And it works with any other OADs. It works with blockade of the SGLT2 receptor, so it is not inherently dependent on insulin for its action. In this particular study, up to 1.2% HbA1c reduction has been shown, but it depends on how much is the baseline HbA1c. If your baseline HbA1c is lower, as happens with any other agent, you would have HbA1c lowering just shy of 1%, and most people would agree that HbA1c is of about 8.5. The drug would reduce the HbA1c by a factor which is slightly less than 0.9, which is more than DP4 inhibitors on an average. But these drugs are more effective at higher HbA1cs compared to DP4 inhibitors. Some people feel that DP4 inhibitors are better at HbA1cs 8.5 or less. If you look at the durability in this instance with the comparator is lipizide, you find that HbA1c is lowered very rapidly with lipizide, not so rapidly with DAPA, but after a certain period of time, precisely about 1.5 years, the curves start closing, and both the things have got an upward kind of ascent, what we call the river and Nike phenomenon. But the patients with dapagliflozin tend to have a more blunter steep rise after a period of time. And at the end of the study, the people who were having more lower HbA1c in the group who received the SGLT inhibitor versus self-inhibitor, despite a good impact. And of course, the difference on weight and hypoglycemia were very much there. You know that these drugs do not cause hypoglycemia and they do not cause weight gain. There are many effects on alpha cell function, and some of them are supposed to be responsible for the beneficial effects on the cardiovascular system in terms of the glucagon excess and controlled ketogenesis. But the data on in this respect is very, very confusing. By way of causing glycosuria, they promote hepatic glucose output through glucagon, which means that increases glucagon, and it has been demonstrated. But by improving insulin secretion, they may also have some impact by paracrine action. By somatostatin release, you have tonic inhibition of glucagon. Experiments on the SGLT receptors on the alpha cells have shown that actually there is a decrease in the glucagon concentration. So this is a very complex issue, and some people feel that the indirect effects may be different in different species and sometimes in the same individual, and depends also on the alpha cell mass. This expression is very variable, and therefore you get different results from different studies. And this is shown in this cartoon, which talks about decreasing glucagon as a result of direct stimulation, but paracrine and the other responses are also involved, and you may get different responses in different individuals. Sometimes you have got no response, sometimes you have inhibition, sometimes you have stimulation. There are, of course, extra glycemic benefits, which are weight reduction, which is proportionate to BMI, and blood pressure reduction. Now, weight loss is not just because of calorie losses. Unfortunately, the other mechanisms are just beginning to be understood. And whatever this is, it is not sustained. You lose weight for about 3 to 6 months, and then it sort of plateaus out. They are implicated to shift the energy metabolism towards fat. And they are also supposed to activate AMP kinase and reduce liver lipid content, and therefore they may have some role in the NASH. The regulation of adiponectin and leptin expression also are invoked in modulation of the appetite. If you are lean, you lose less weight, but if you are obese or overweight, you lose more weight. So at the very extreme, when you have got BMI of 18.5, you will have just a very bare minimal loss of 1 kg, but at higher BMIs, when you are more than 40, you lose much more weight. So on average, you stand to lose 2.8 to 3 kilograms of body weight. There are also some mechanisms which are supposed to underlie the pathogenesis and treatment of heart failure and diabetes. We know that the insulin and glucose can work through neurohormonal mechanisms by stimulating the NHE1 activity in the heart and vasculature and NH3 in the kidneys. And this can cause sodium retention and cardiac hypertrophy, and also impair the insulin sensitivity and worsening glycemia. By way of SGLT inhibitors, They inhibit NHE3 in the kidneys. It may also inhibit NHE1 in the heart, not directly, but through a binding site on NHE1. Such an action might ameliorate cardiac injury, hypertrophy, fibrosis, independent on their action on the renal sodium absorption or blood pressure. There is also natriuresis, which Ratan Chah will tell you is responsible through tubuloglobular feedback mechanisms to contribute in some ways to reduction of the intraglomeralular pressure, amongst other things which with which kidneys benefited. And this will therefore be responsible, along with the RAS blockade, to have a complementary dual action on the efferent and afferent arteriole. Dapagliflozin, as we know, reduces the systolic and diastolic blood pressure. The numbers look 5.1 and 4.2. You may wonder what is this, but you would realize that this translates into significant cardiac and cardiovascular benefits. In summary, patients with type 2 diabetes mellitus at high risk for major vascular complications, heart failure, and CKD. Dapagliflozin has positive impact on metabolic factors, and mind you, controlling diabetes is responsible for reducing the microvascular risk in and by itself, even beyond their action on the kidney and the heart, which the subsequent speakers will discuss. They do reduce HbA1c, weight, and they have some pleomorphic actions like systolic blood pressure, decreasing the uric acid, improving the function, which the other speakers will speak about. This is the only FDA-approved SGLT inhibitor for treatment of heart failure based on the heart failure study, and might now be also recognized as an agent for kidney disease. Dapagliflozin has also shown, as I said earlier, a reduction in the development of diabetes. So this is one and the only D4 inhibitor which is shown to prevent development of diabetes. We have metformin, we have acarbose, and we have orlistat. In the past, we used to also harp upon the glitazons. But amongst the DP4, the SGLT inhibitor, this is one agent. So for glycemic control, for organ protection, for prevention of diabetes, and what you have, including blood pressure lowering, weight loss, not causing hypoglycemia, there are many benefits of SGLT inhibitors, and what you call in Hindi, sarvaguna sampanna. So it looks as though if it's used properly, appropriately in patients who do not have contraindications to this and who tolerate this drug well, this drug seems to be a good drug, and it is known to reduce the risk of kidney failure and renal death in patients with the CVD, and also has some action CKD. I will not tread on the toes of my subsequent speakers. Apologies for my voice. The subsequent speakers do not have only beautiful voices, but they also are very good speakers, and it's very difficult for me to compete with them. Therefore, my talk was placed before them. I would hand over the mic to the podium, so to say, to the organizers, and so that the other speakers can present and take you through.